How's it going? Good to see you all. Thanks for coming. Hope everybody's having a good time at SAEM. It's good to see everybody in person again. So, wow, packed room here, so it's great. So I wanted to introduce our panel. We have a few speakers today that are going to go through a few different studies, and we worked hard to try to pick really high impact, well done studies, mainly randomized controlled trials, to demonstrate the impact that high quality research can have in low and middle income countries and often in lower resource settings. And really with the overarching theme of showing that high quality research can and should be done in every part of the world, and that it's really important that high quality research is done in low and middle income countries, because you can't just apply the findings from high income countries to other parts of the world. It just doesn't work like that, and things don't hold up. So that's the point of this, is to demonstrate some examples of good research and a little bit about their method so that you can think of how you would do it on your own. And also to talk a little bit about authorship equity, and both in authorship of papers but in funding streams, and to make sure that there's collaborative research performed when it's partnerships between high-income countries and lower middle-income countries. So we're going to talk a little bit about that as well. So with that, I want to introduce our group here that we have. So we have a wonderful panel, and I'm going to give everybody's bios here, and then we'll get started. So first is Dr. Chantal Uamahoro, who is a junior Chantal right there, so in the middle. Is a junior consultant in Accident and Emergency Department, University Teaching Hospital of Kigali, or CHUK, and is a clinical lecturer in emergency medicine at the University Teaching Hospital of Kigali at the University of Rwanda since 2018. She completed her medical training at Hope Africa University in Burundi and specialized master training in emergency medicine and critical care at the University of Rwanda. She is the first female emergency medicine physician in her home country of Rwanda. Quick round of applause. Yeah. Yeah, really incredible. And she is a founding member of the Rwandan Emergency Care Association. She worked with the organization to host their first conference in 2016 and the African Conference of Emergency Medicine in November of 2018. She participates in the Emergency Medicine in the Tropics course offered annually by the Rwandan Emergency Care Association for foreign doctors and medical trainees to learn about the practice of emergency care in Rwanda. She has been involved in many research projects and educational aspects in international conferences around the world, and it's really our distinct honor to have her here with us in New Orleans and in the United States. So thank you for coming to be with us and to speak today. Next, we have Dr. Kaushila Thilakasri, who is acting consultant in emergency medicine at the National Hospital of Sri Lanka. She is the European Resuscitation Council Young Representative for BLS and a council member of the Sri Lankan Society of Critical Care and Emergency Medicine. She's also a member of the Royal College of Emergency Medicine. Her research publications are on resuscitation and medical education. She's involved in teaching and developing numerous local acute care and emergency medicine training programs for students and CME programs for junior doctors. She is a committee member of the Gender Specific Issues Special Interest Group. She's contributed to develop near-peer learning module in emergency medicine for the University of Colombo and for the Faculty of Medicine there. She's volunteered as the Director of Training at St. John Ambulance in Sri Lanka for the past 7 years. And she was the recipient of the Global Travel Award of the AWEM, the Academy of Women in Academic Emergency Medicine, given out by SAEM in 2020, which could not travel because of COVID. So she's making good on it now. So thank you so much, Dr. Thilakasri, for being here. And thank you for traveling all the way from Sri Lanka to be with us and teach us about research. And next we have, with a far shorter commute to the conference today, Dr. Adam Layton. So he is assistant professor of emergency medicine, anesthesia, and critical care medicine at Johns Hopkins University School of Medicine, where he divides his time between the ED and the surgical ICU. He's also core faculty at the Hopkins Center for Global Emergency Care and the vice chair of the IFEM Critical Care Special Interest Group, which is a sponsor of this talk. His research focuses on the burden of medical emergencies, critical illness, and trauma in low and middle income countries. in order to develop data-driven quality improvement and capacity-building initiatives. So, and a little-known fact about Adam is that he almost went down the horrible dark pathway of being a surgeon, but luckily we were able to pluck him away from that halfway through his training and turn him into an ER doctor. So thank you, Adam, for being here. And also thank you, Adam, for putting this all together, because this is sponsored by the group he leads at IFEM for critical care in partnership with SAEM. So thank you, Adam, for being here. All right.
And thank you, Sean, for saving me from the depths of general surgery.
Yes, that's what I'm here for. So, and I'm Sean Kivlehan. I'm an emergency medicine physician in Boston. I am the fellowship director of global emergency medicine at Brigham and Women's, and just happy and honored to be here to moderate this panel today. So thank you all for being here. And we do have a special guest in the end who's hiding in the crowd, who is going to give a last few slides there, Dr. Catalina Gonzalez-Marx, who I think, yeah, there she is, she's hiding. So at the very end, we're going to talk about the overarching themes of authorship equity, and Catalina is going to walk us through some of her amazing research on that. So we'll save that for the end as the last little slide as a trailer for her talk she's giving at 2 o'clock. Okay, so with that, why don't we go first? Chantal, or who wants to, I think you can go first. Oh, no, yeah, this is you. Okay. We messed up the slides, but this is, okay, here you go. Here you go. That right there. Either one, or that.
Okay. Thank you. Hi, everyone. I'm going to present on to compare 2 papers. One was the effect of early tranexamic acid administration on mortality, hysterectomy, and other morbidities in women with postpartum hemorrhage. So the other one was the secondary analysis of that paper, which was on the woman trial. So as background, the PPH is the leading cause of maternity death worldwide, and there is a high mortality from PPH in low and middle-income countries. So TXA is already used in many resource-limited locations due to its availability and low cost. So the woman trial was designed to answer this question. Does the administration of tranexamic acid compared with placebo reduce death from bleeding in women with postpartum hemorrhage? So this was an international randomized double-blinded placebo-controlled trial where patients were recruited from 193 hospitals in 21 countries. And women aged of 16 years old and above were included with a clinical diagnosis of PPH. And also the exclusion criteria was when the clinician felt it could be inappropriate for individual to receive or not receive tranexamic acid, or some other treatment could be offered outside the trial. So the PPH was diagnosed clinically based on the estimated blood loss of above 500 mils of blood after vaginal birth, or above 1,000 mils after cesarean section, or any blood loss sufficient to compromise the hemodynamic stability. The sample size was 20,000 patients. So women were randomly allocated to receive either 1 gram of IV TXA or matching placebo by selection of a blinded treatment pack. So if bleeding continued after 30 minutes or restarted within 24 hours after first dose, participants were given a second dose of 1 gram of TXA or placebo. And outcomes were monitored at time of death, at discharge, or at 6 weeks after randomization. So, in total, as a result, 20,060 women were included, and among them, 483 maternal mortality were recorded. And the TXA was found to be significantly reducing death due to bleeding in all cause of death. So, as I said, 483 maternal deaths were recorded with a case fatality rate of 3.0% in Africa, 1.7% in Asia, and there was no death in Europe. Most of women who died, the cause of death was bleeding at a rate of 72%, but other 28.4% cause of death were not non-bleeding causes. So this was applicable because the TXA was added on the World Health Organization set of recommendations for the prevention and treatment of PPH based on the women trial results. Also, the secondary analysis allowed more detailed examination of causes of death in low and middle income countries. Also, the bleeding was the leading cause of death, but most women in this study received the treatments aimed to prevent and stop bleeding growth. And importantly, they also received blood transfusions, which should help preventing death in cause of majority of when there was major PPH. So here the use of narratives was excellent because they could learn more about factors contributing to cause of death, and also they identified multiple risk factors which may be contributive to maternal death. So this was equitable because on the primary paper, the study group had representations from broad geographic areas, and also on the secondary analysis, the first author and the last author were in UK, but other authors from Cameroon, Pakistan, Sudan, and Zambia were also represented. And this covered the geographic area of Europe, Asia, and Africa, which were the study sites. And also this is the key of finding, it's the key finding of well-done global research studies done in equitable manner. So using multiple data collection methods was helpful in low and middle-income countries, and also using narratives allows researchers to get a better sense of cause of death and patient causes where you do not have access to the full chart. So as a summary, the secondary analysis, the secondary study highlights factors contributing to death after PPH, and also the blood loss was the leading cause of death, and the narratives emphasized the lack of blood for transfusion, either from blood shortage or the inability to pay for it when it was available. So also, two important changes happened with the study after it was commenced. One was that the sample size was increased by 5,000 patients during the study, and also the study hypothesis was refined after commencing the study in light of causes of findings from the CRASH 2 study, which was published in 2011, and the mortality with death due to bleeding was changed to main secondary outcome. Also, patients were enrolled in the study if clinicians were uncertain if they would benefit from TXA or not. Also, another issue was that there was no formal screening for embolic complications, and perhaps these were missed. So this is the end. Thank you for your attention.
We'll do questions at the end, and Kaushila.
Hi, I'm Kaushila. I'm an emergency medicine acting consultant from National Hospital of Colombo. So thank you very much for giving me this opportunity to talk today. I'm going to talk to you about a randomized control trial which was done in Sri Lanka in collaboration with Australia. This was published in the Journal of Thrombosis and Hemostasis, a randomized control trial of fresh frozen plasma for coagulopathy in Russell's viper envenoming. So I'll be explaining a bit about the background and then the research question and then the study design as well as the key results. Then we'll look at how applicable and locally relevant this was, and equitability and engagement involved, challenges and adaptations, and also the key lessons that we can take home. So I have nothing to declare as conflicts of interest apart from being a big fan of this Russell's viper snake. It's fascinating. So why do we need a randomized control trial on a snake bite? So snake bites is one of the major conditions that causes mortality and morbidity for millions of people in the resource-poor countries. And randomized control trials are extremely rare. So there are snakes in developing countries, and there are snakes which do not exist in developing countries, like the Russell's viper. Russell's viper exists only in South or Southeast Asia. Therefore, there were no randomized control trials on treatment for Russell's viper. But there are randomized control trials for snakes that live in Australia. So therefore, a randomized control trial on this snake is a very significant research done in our part of the world. And what is venom-induced consumption coagulopathy? I just need to speak about this a bit, otherwise it would not be easy to understand the trial, because this is a geographically isolated condition I'm talking about. So venom-induced consumption coagulopathy means when snake venom enters your body, it starts consuming all the coagulating factors, so much so that the body cannot coagulate anymore. And you would see something like this in the urine bag. So you start bleeding from all ends. So that's what happens in consumption coagulopathy. It also can lead to strokes, not only hemorrhagic strokes, but also ischemic strokes because of consumptive coagulopathy internally happening. So this is how bad gets, and this is the worst condition that causes mortality in snake bites in South Asia, and it's the commonest cause of death. So that is why a treatment for this is very important. Okay, so how do we detect that somebody is going to go into venom-induced consumption coagulopathy? We use a method called 20-minute whole blood clotting time. So INR would be the ideal, but INR is not available readily. Therefore, what we do is we take 5 ml of blood into a plain tube and keep it without agitating for 20 minutes, and then turn it upside down at 20 minutes to see that it's clotted. So that's called 20 WBCT, or 20-minute whole blood clotting time. So this was used in this study, and you'll realize how it was used at a later stage. So what evidence is available for treatment and controversies? When it comes to treatment, as I said, there are no RCTs. Therefore, there were two schools of thought. So one school of thought was that you should give 10 vials of antivenom. And the other physicians thought, no, you should give 20 vials, because there were evidence for 20 vials of antivenom in India for Indian Russell's viper. And there were another school of thought that you should add FFP to this treatment, because the Australian elapid, who also caused venom-induced consumptive coagulopathy, showed benefit from that. But there were people who thought when you give FFP, as opposed to treating coagulopathy, it aggravates coagulopathy. So these were the controversies in management they had before this trial. Okay, so what were the research questions? The first research question was, would FFP hasten the recovery of coagulopathy in patients with Russell's viper bite after administration of 10 vials of antivenom? And then the second research question was, would the administration of FFP reinitiate consumption process? So as I said before, some thought that it might again start coagulopathy if we start giving FFP. So these two questions were addressed in this research. It was an open-label randomized controlled trial. This was done only in 2 sites, so 2 base hospitals in rural Sri Lanka, Kurunegala and Polonnaruwa. The population they selected all the snake bite patients who entered through these 2 hospitals over 2 years. But the 2-year period was different, like the dates were different, they selected 2 years. The study design consists of including criteria of more than 15 years and suspected Russell's viper bite, so with coagulopathy. So there are other snakes. There are 4 types of venomous snakes in Sri Lanka, but coagulopathy is caused only by 2 of those types of snakes. So there is a difficulty in exactly determining whether it's Russell's viper or humpnose viper. But later on, they analyzed it in laboratories, whether it's Russell's viper or humpnose. So anyway, availability of sufficient FFP was also a limiting factor for inclusion. Then exclusion, they removed all the pregnant patients, those who are allergic to treatment, and those who were bitten by other snakes. Also, if you note, there is a very important criteria, that is the physician had the opportunity to decide not to include the patient. And these were the 2 measures taken. So they gave 20 vials as the control, which was the common practice at that time, and 10 vials plus FFP 4 units within 4 hours. Right, so this is how they randomized the sample, and this is how they tried to match the 2 intervention and the control, sex, age, type of snake, hospital, and then time of admission, time of antivenom administration. So if you look at the ethical clearances they obtained ethical clearance from both ends, from Sri Lanka as well as Australia, and all patients gave written informed consent. This was included in the Sri Lankan Clinical Trials Registry. So there were 2 outcomes they measured. The primary outcome was the proportion of patients with an INR of less than 2 at 6 hours after antivenom administration. This was considered as recovering from coagulopathy. And then secondary outcomes they measured included anaphylaxis, major hemorrhage, death, clotting factor, recovery time. So when it comes to primary outcomes, there was no clinically significant difference in the two low dose versus the high dose group. If you note here, the total snake bites were 2,076, but only 214 got eligible, and the physician decided not to take for the trial 73 of them. So the secondary outcomes, systemic hypersensitivity reaction, severe anaphylaxis, recurrence of venom antigenemia, hypofibrinogenemia, repeat antivenom dose needing one or more, major hemorrhage, death, none of these had a clinically significant difference between the two groups. So the authors concluded FFP after antivenom did not hasten recovery, low-dose antivenom or with FFP did not worsen venom-induced consumptive coagulopathy, and low-dose antivenom appeared to be as effective as high doses. So how was this applicable and locally relevant? Well, I already explained you how it is a major disease, comorbidity causes comorbidities in developing world. The interventions was realistic, for example, using the whole blood clotting time instead of INR. And if you look at the equitability and engagement, this study had 11 authors, and out of them, 5 were Sri Lankans. And Dr. Kalnamaduwage, whom I also personally know, was a PhD student of Professor Isbister at that time of the study. And I've also spoken to him about how equitable and engaged this research was conducted. So they were all quite happy of how it went on to be. And if I make a note, this study was completely funded by the Australian government, but this is not a snake that exists in Australia. It is a snake that exists in Sri Lanka. So it's the funding that Professor Ibister received for his research that he utilized to do this research. So challenges and adaptations, limitations-wise, using whole blood clotting time versus INR was a big limitation, because actually before they gave antivenom, they took blood samples which were frozen and later analyzed in Australia. They found that some of these patients who had a prolonged whole blood clotting time actually did not have a prolonged INR. So if INR was used, some of these patients might have actually been removed from the study. But in our setup, using INR would not be realistic. So using INR and commenting on a treatment protocol would not be realistic. So it was a major adaptation, yet a limitation. Then weakness-wise, this study sample size was calculated to have 170 patients to have its adequate power. But it ended up with 136 samples, so the power was not adequate. So that was a major weakness here, and only 2 centers were used, but although Russell's viper bites are common all over the island, this only covers 2 districts, but the country has 26 districts. So challenges-wise, blood sample analysis was a major challenge they faced. There were no laboratories in Sri Lanka to detect venom in blood, to detect many other clotting factors. So they had to, this venom and clotting factors were volatile, so they had to freeze the sample and send it to Australia. And they used several measures like dry ice and every 7-minute temperature measuring mechanism to make sure that the sample was actually transported in correct temperature to prevent losing the quality of it. Then so this is what I just explained. And they also analyzed later the patients who had a normal INR and a prolonged whole blood clotting time, and they actually saw a greater effect from FFP when they excluded those patients. So the key lessons. Lesson number 1 is Sri Lankan National Guideline on Snake Bites adopted this clinical trial, and a major guideline change happened. So we were giving 20 vials for all Russell's viper bites. After this study was published in 2017, the national guideline changed into starting to use 10 vials as opposed to 20 vials. And it really became cost effective. And also, this study tells us very loud that if a geographically isolated question can be answered in such a way, and it has value for high-income countries like Australia, for its research on snake bites and its further development, why not adapt it to common problems that we all have? So it's a great example, I think. And thank you very much for giving me this opportunity. This is my beautiful country. It was named the 2019 Best Travel Destination, if any one of you are interested in. Thank you.
Thank you, everybody. Before I start, I want to just thank again our panelists for joining us. I'm really humbled to get to speak with two luminaries in emergency medicine in their countries. I'm also really grateful for all of you guys being here and for everybody who's standing in the back for standing. I think it's a great testament to the enthusiasm and the interest in doing high-quality research in low-resource settings within the SAEM community. And so I look forward to having more talks with more seating room in the future. And thank you guys all for bearing with us. As Sean said, my name's Adam Layton from Hopkins, and I'm going to be discussing the ACOS trial. So this was published in The Lancet last year, looking at patient care and clinical outcomes for patients with COVID-19 infection admitted to African high care or intensive care units. This was a multi-center prospective observational cohort study. And I'll try to go quickly through this so that we have a little bit of time for questions and discussion. So excuse me for talking. I would talk fast even if I wasn't trying to go fast, so just bear with me. So this was a study done in 2020. At that point, they already knew that the SARS-CoV-2 virus had overwhelmed healthcare systems around the world with high rates of critical illness. Patient outcomes with COVID-19 were not sufficiently documented in Africa, but they hypothesized that critically ill patients with COVID-19 in Africa would have worse health outcomes than in other continents because the ability to provide sufficient care was compromised by a small workforce, low numbers of intensive care facilities, and a scarcity of critical care resources. They also hypothesized that unplanned admissions would adversely affect critical care outcomes in Africa because of the limited availability of the healthcare systems to meet the increased workload. So like I said, this was a multi-centered prospective observational cohort study. This was open to all African countries, of which 10 were able to fulfill the ethical and regulatory requirements to participate, and a total of 64 hospitals from around Africa contributed data to the final study population. Patients were followed until hospital discharge, or for 30 days, and recruitment started May 7 and went through from May through December of 2020. So again, this was, I know it feels like decades ago, but remember that in February in America, we were still hearing this is not a global health concern and not something that we should worry about. It's going to go away just like the flu. Within really 3 months of the pandemic starting in full force, they managed to organize the study, come up with a study design, enroll 64 hospitals, and start data collection, which I think is really a phenomenal accomplishment. Primary outcome was in-hospital mortality within 30 days of admission, and secondary outcomes were looking at factors associated with mortality, including human and facility resources, including the level of care, number of hospital beds and critical care beds, reimbursement status and nurse-to-patient ratio, patient comorbidities, and critical care interventions. So a couple of key study features. Sites were asked to include all eligible patients and recruit for as long as possible, but the authors made a point that they told sites that they could stop recruiting at any point if they were overwhelmed by clinical commitments. And this was still very early. We weren't sure how hard COVID was going to hit Africa at that point, and they wanted to make sure that the balance between providing optimal service for their patients and collecting the highest quality of data possible, that those interests were balanced as well as possible. They had primary ethics approval from the University of Cape Town, where the principal author was, and they used consent either from patients, representatives, or proxies. They had a sort of interesting opt-out approach to consent with delayed consent. So because many patients were unable to consent at the time of admission to the ICU, they started collecting data, and then when either the patient was able to answer for themselves or a proxy was identified, they would then ask if they were okay with having their data included in the trial, and allow the opportunity to opt out. So all sites fulfilled local ethical and regulatory requirements, and some of the hospitals, local IRBs waived requirement for consent altogether. But they had that variability really to respect the varying assessments of IRBs in those 64 different hospitals. I'm going to take a minute to go over, and it projects small here, but I wanted to just show you guys the data collection form for this. And so I broke it up into 2 slides, but this was a single sheet of paper, and I think is really masterfully done. As somebody who's done data collection in low resource settings before, I am like in awe of the elegance of this. And so you can see that most of these are check boxes for yes or no questions. There are places where like age up here or patient's height and weight to calculate BMI involves writing in digits, but there's no free text here. This is a very lean, very elegantly designed data collection form that really breaks down to one single sheet of paper, and then it has the patient name and hospital number at the bottom there, but then that can be torn off so that right away you have anonymized data collection. And they did this in a very streamlined sort of a way. So looking at key results, 6,779 patients were referred to critical care within the hospitals included in the sample. Of those, about 55% were actually admitted to an ICU or high care unit, which is sort of the equivalent of what you would think of as a step-down unit or an intermediate care unit in most of our settings. This is somewhere where a patient could be closely monitored, provided with advanced non-invasive oxygen support like high flow or BiPAP, but not have invasive ventilatory care. And of the 55% of referred patients who were actually admitted to an ICU, 84% of those patients actually had data collected that was included in the trial. And so, a very impressively high capture rate for this study, for the patients who were enrolled. I'm going to go through the results a little bit more. So looking at those hospitals, 70% of those were tertiary care hospitals, 88% were government affiliated, 77% were university affiliated. So certainly not representative of all hospitals and all ICUs in sub-Saharan Africa, but those were the hospitals that were able to collect and contribute data. On average, these hospitals served a population of 2 million with 500 hospital beds and 12 ICU beds. On average, hospitals had 2 intensivists working there with a nurse-to-patient ratio of 1:2 and a doctor-to-patient ratio of 1:4. Almost all of the hospitals had a clinical laboratory on site, but only 82% were able to run blood gas analysis, and almost 40% didn't have walled oxygen, so they were reliant on oxygen cylinders for oxygen support. And then only 86% of those hospitals were able to do continuous pulse ox monitoring for all of their patients. 70% were able to prone, 68% were able to provide renal replacement, and I was sort of shocked to see that 16% of these hospitals were able to provide ECMO support. So again, not entirely representative of all hospitals in all of Africa, but I think the best quality of data of critical care care provision and outcomes that we have available really for any pathology. They found that mortality following critical care admission for patients with a suspected and confirmed COVID-19 infection was 48%, and this was compared to a global mortality estimate of 32%. So that's 53% higher than in other continents. And they estimated an excess mortality in critically ill COVID patients between 11 and 23 deaths per 100 in Africa. Of the patients who died, only 64% were intubated prior to death, and less than half received vasoactives prior to death. And an adjusted analysis suggested that critical care mortality was associated with increased age, HIV, diabetes, chronic liver disease, and chronic kidney disease, initial need for increasing respiratory and cardiovascular support on admission, and ICU admissions that were delayed due to lack of resources. Notably, they found that the QSOFA score on admission was significantly associated with patient mortality. They found that when the data were available to calculate a full SOFA score, that actually did have a stronger association, but because of lab limitations and resource limitations, that wasn't a feasible metric to use in many of these hospitals. And they found that QSOFA was a adequately accurate surrogate. So in terms of the applicability and local relevance of this study, this was the first study reporting on COVID-19 outcomes in a large, diverse cohort of critically ill African patients. And it highlighted local challenges in the care for critically ill patients, including adequate ICU beds. So you'll remember that only about half of the patients who were referred for ICU care or for critical care were actually admitted to an ICU and included in the sample. And the limitations of resources even within those ICUs. So things that we probably take for granted, like pulse oximetry and blood gas analysis, were not universally available. And things that have been shown to be life-saving for severe COVID-19, including ability for proning and renal replacement therapy, also were not always available. The authors were able to identify context-specific risk factors for mortality to inform vaccination strategies. So they noted that the patients who were high risk for mortality from COVID-19 in the US or in other high-resource settings may not be the same patients that are high risk in Africa, and this allowed them to use African data to inform local strategies. They also identified the QSOFA as a locally accurate risk stratification tool that would be helpful in facilitating triage going forward. And finally, this really showed the importance of local data to support advocacy for critical care capacity building. You know, I think that there historically has been a lot of bias and a lot of assumptions that critical care is not effective or resource appropriate in low resource settings. And I think that they were able to show that when patients were able to get the care that they needed in a timely fashion, that the African intensivists were able to save a tremendous number of lives during the COVID-19 pandemic. There were 37 authors from 12 different countries. One of those was British, and all of the other authors were Africans. Each country and each hospital had a coordinator that had explicit responsibilities, and they were all able to provide input to a 14-person steering committee that took all of that input and feedback and integrated it into a protocol that was feasible in all of those different diverse centers. And then, as I had mentioned, they accepted some variability in local IRB guidance in terms of which patients should be included and how exemption of consent should be addressed. In terms of challenges and adaptations, they used a context-appropriate data collection strategy. As I showed you, they had those paper case report forms that were then pseudo-anonymized and transcribed into an encrypted internet-based form using REDCap. They also had the option that those paper forms could be mailed to the lead investigators team in South Africa for transcription in countries with poor internet access. They used innovative modes of communication to coordinate between all of the different members of this big research team, and so relied heavily on WhatsApp for communication to keep everybody coordinated. And they did all of this tremendous work with really minimal funding. They had support from the Critical Care Society of Southern Africa for the REDCap platform, and the rest of this was totally unfunded and all through the efforts of the local researchers and collaborators. There were a couple of limitations. They were unable to include patient information for those who were referred but not admitted because of the lack of informed consent. And so even though of the patients who were admitted to the ICU, we saw that 48% mortality, of the patients who were referred for ICU care, for critical care, we can assume that that number is probably much higher because of all of those patients who didn't have access to life-saving care. Again, as I pointed out earlier, this was a relatively high-resource cohort of hospitals within Africa. And so the authors made a very conscious decision not to randomize or purposefully sample hospitals and really used convenient sampling to try to collect as much data as they were able to. And there's always the possibility they may have had incomplete data capture for the admitted patients. I had the great privilege of actually speaking on at a workshop with Bruce Picard, who's the lead author of this paper, a couple weeks ago. And so I got the opportunity to pick his brain about how he thinks that they managed to make such a tremendous research achievement with such limited resources and in such little time. And so a couple of things that he really stressed. One was the pragmatic study design. So starting with a very focused research question and really only collecting the essential data needed to answer that specific question. And he said that a more cumbersome data collection strategy would have led to increased attrition and lower capture rate. He said their success really relied heavily on communication and good relationships. Said they were able to resolve most issues through conversation with local sites as concerns arose. And I think what really stuck with me the most was that he said, we must be impactful, otherwise we're wasting our very limited resources. So I'll stop there and hand over to Sean. Thank you all for your time.
Thanks so much, Adam. And last, we have a few-minute bonus slides here by Dr. Catalina Gonzalez-Marx, she's going to give us some insight into her recent work on authorship equity and a preview into the talk she's about to give in about 10 or 15 minutes.
In about 5 minutes. Thanks, John. So first thing, this is not my study. This is everybody's study. This is a huge team behind this, led mostly by women, I will say, and experts in emergency care across the globe. So I think the first thing is that we know, and I'm talking really fast, one, because I'm Latina and it's just a habit, but also because I do have to run. So high-income country authors are disproportionately represented in authorship bylines compared to our colleagues in low and middle-income countries. We know this. But there's a group of us from the Decolonizing Global Emergency Medicine Task Force who was like, well, we need to look at ourselves. If we want to do this work and be more equitable, how are we doing? And we actually do thank GEMLR, the Global Emergency Medicine Literature Review, which very nicely handed over and said, take all the data, tell us how we're doing. And so we're like, how are we doing? Are we equitable? And how are our academic collaborations in the field? And so what we did is we took all the articles over the last 5 years from GEMLR that was data collected in a low and middle income country, and we looked at authorship position. And so first author. So this is actually where all the studies were from, kind of like a pretty robust study of we got a good amount of studies from different countries in the world. But if you look at first author, the darker means where most of the first authors were from. And surprise, surprise, no surprise to anyone, leading the way was the UK, the US, and South Africa also as well, and Sweden was also very high. So first authors were disproportionately represented by our high-income countries. And then the green again is the distribution of where the studies were. And when we looked at last author, unfortunately the pattern didn't change and was actually worse, with the darker purple indicating a higher concentration of authorship representation from those countries. And so I'll just let it settle in for a second. And again, it was the US, the UK, Canada, and Sweden leading the way. And so again, there are significant disparities in our own global emergency medicine authorship representation, and high-income countries are more commonly occupying these prominent authorship positions. And it really begs the question, are we valuing the true expertise, which is not only the lived experience, but the physicians who are the true experts in emergency medicine in their countries? And then how are we recognizing and addressing these power imbalances, and what are other ways that we need to look at ourselves as academic institutions to kind of work on this? And our conclusions are really, we need to be more innovative and look at this more, kind of more aggressively. And our group will also be looking at funding and support from EM researchers and how we can really be more of a collaborative global emergency medicine community. And I have to say some of the other authors on this paper are here. Dr. Sharma and Dr. Kaushila are also here, who are authors on this paper. We just submitted to Global Health BMJ. We expect to be rejected, but we'll keep going till it's published and we have further studies. And if you want to hear more, please come to our talk in like 5 minutes in C1. Thanks, everyone.
Thank you, Catalina. Well, that's time, so we're going to wrap it up there. And I just want to, again, thank everybody. The goal here was to show that high-quality research can and should be done around the world in the areas that research is meant to target. And really, all of us in this room, by the fact of the matter that we're here at SAEM, we're academic emergency physicians, we're largely high-income based, and it's really up to us to drive this change and to look inward at our own research practices, our partnerships, our funding streams. And it's high time that we have this conversation. So it's really a goal just to get the seed planted so that we can continue these conversations. So we'll be around for questions, but I'm going to end it there so that people can move on if they have to. Thank you again to our panelists, and thank you to all of you.